So hello everybody, and thank you very much for joining us. Today we're going to have a recorded session from Declan Costello. He's going to talk about laryngeal surgery and management of vocal cord paralysis. I listened to it before, and it's really very interesting stuff. So please join us, and I'm going to start the recording. Thank you. Hello, everybody. So welcome again for our next session. We have today Declan Costello, and I have here with me Dr. Osama Al-Ani.
Hi, how are you?
So Dr. Osama Al-Ani is going to be sort of co-moderating this with me, and going to let him introduce Declan. So I'm going to unmute Declan's. I don't know why I can't unmute it. Okay. Hi, Declan.
Hello, hi. Nice to see you.
Nice to see you. So I'll leave you with Osama here.
Hi, Declan. How are you? Nice to see you again.
Very good, Osama. It's been a while.
Yes. So I will introduce Mr. Declan Costello. He is a consultant ENT surgeon with special interest in voice and laryngology. He's going to talk to us about his experience in laryngology and vocal cord palsy management. Okay, for you now?
Perfectly good. Yeah, that's great. I'm going to share my screen with you. Thank you very much indeed for the invitation to speak today. If at any stage you can't hear me, or if there are any problems, then do interrupt and let me know, and I'll pause and go over things again. So I'm going to talk to you for
Declan, if you could just increase the volume a bit. I don't know how you could do that.
Okay, can you hear me okay now?
I think this is good now.
Okay, so I'm going to talk to you for the next hour or so about vocal cord paralysis, my thoughts on investigation, and particularly on how treatment of vocal cord paralysis has changed over the last few years. Now, I'm just going to share my screen with you. Bear with me a moment here. Great. So I hope you can all see my screen now. Osama and Muaz, can you just wave if you can see my screen?
Yes, we can see it.
Perfect. Very good. Okay. So we're going to talk about the modern management of vocal fold paralysis and various different aspects. So you'll be familiar with the clinical scenario of a patient with a vocal cord paralysis. It's a very common problem seen in our voice clinics. The patient will present with a weak and breathy voice and an ineffective cough, the so-called bovine cough. Now, patients will often aspirate as well because of the ineffective vocal cord paralysis, and we know that this causes problems not just in terms of morbidity, but also mortality. The take-home message from this talk really is that it's no longer reasonable to just watch and wait. There was a time when we would say that you wouldn't intervene surgically for quite a long period of time, and you would wait to see how the patient compensated, or wait to see how whether the vocal cord paralysis was going to resolve. But the new message, and this is rewriting all of the textbooks that you will have read, but the new message now is that you don't watch and wait and see what happens. Historically, patients would have been sent for speech and language therapy over a period of 6 or 9 or even 12 to 18 months before deciding what you were going to do. And at that stage, you would have decided to augment the vocal fold with either an injection medialisation under general anaesthetic or a thyroplasty. And I will talk about thyroplasty as we go along, but you'll be familiar with the idea of medialising through an external approach in the neck. In terms of investigations for vocal cord paralysis, if there's no obvious cause initially for the vocal cord paralysis, in other words, if they haven't had a recent surgery on their neck, then we would routinely perform cross-sectional imaging from the skull base down to the diaphragm. And whether you do an MRI scan of the neck and a CT scan of the chest, or whether you do a CT scan of neck and chest, is really up to you and your local protocols and your local radiology expertise. I've said here that you could consider doing an EMG. Now, why would you consider doing an EMG? Well, electromyography can give you some useful prognostic information sometimes about whether a vocal cord paralysis is likely to recover. So it gives you that sort of prognostic information. But you might say, well, we know that we're going to be treating patients early, as I'm going to show you in a moment. We know we're going to be treating patients early. So actually, in a sense, the likelihood of resolution of the vocal cord paralysis is of less interest. It might be interesting to the patient to know, but we know that we're going to be treating the patient early now anyway. So as I say, we will typically be offering early treatment in the form of local anaesthetic vocal fold injection to all of our patients. So I'm going to talk quite a lot in this next little while about vocal fold injection under local anaesthetic, because I think it really has changed the shape of what we're doing for patients with vocal fold paralysis. Why would you do a local anaesthetic medialisation injection? Why not take them to the operating theatre to do it there? Well, the patients prefer it. If you say to a patient, I can do a procedure that's going to take 10 minutes or so in the clinic with you awake, the vast majority of people will prefer that. There's no need for a general anaesthetic, and you can see and treat patients there. Now, that's particularly helpful for oncology patients. If you have a patient who is palliatively ill with, say, an esophageal cancer or a lung cancer, the ability to give them back their voice straight away is really extremely important. It gives a very quick fix for people who need a rapid improvement in their voice. So professional voice users, whether they're lawyers or doctors or clergy or call centre workers, teachers, anybody who's using their voice professionally really deserves to get their voice back as quickly as they possibly can. And I think the key thing for me is that when you're doing these injections under local anaesthetic, you can see how much of the injection material you need to put in. You get a very precise measure of until you get the vocal fold closure just right. Whereas if you're doing it under general anaesthetic, you're sort of guessing how much of the material needs to go in. And for me, one of the key advantages is being able to gauge, being able to judge exactly the right amount of filler material to put in so that you're getting good glottic closure. The injection materials we use have changed over the years. I use either Radiesse Voice or Renew Voice, both of which are calcium hydroxylapatite, which is it's got the texture of paste, sort of toothpaste. It lasts about 12 to 18 months, and you can get with it a non-coring needle so that as you go through the skin, you don't pick up a plug of soft tissue. So that lasts a reasonably long time. Restylane is hyaluronic acid. It obviously used extensively in cosmetics as a filler. Typically lasts about 4 to 6 months and has the texture of soft gel. Now, the Restylane, the hyaluronic acid, is ideal for patients where you think their voice is going to recover over the next few months, but you want to give them a treatment now to help them get through that period until you decide whether things are going to get better. There is another injection material, Radiesse Voice Gel, but that's not available in the UK. And by the way, for our American colleagues, Radiesse Voice is now marketed as Prolarin. Its name has changed for reasons I don't really understand. And I think the marketing of Radiesse Voice is likely to change over the coming years anyway. In the past, there were other materials available. Apologies for the beeping in the background. In the past, there were other materials available as well. Collagen is no longer available in the UK. Gel foam, fat, and you can't use fat under local anaesthetic, but a number of my colleagues use this under general anaesthetic. And it's fine, but obviously requires harvesting for the abdomen and then preparation and then injecting into the vocal fold using a particular long syringe and needle. I've never used fascia. And then Bioplastique or Vox is an injection material that comes with its own ratchet gun. It's a very viscous material injected into the vocal fold. I've moved completely away from using Vox. I've seen a number of problems caused by it when you over-inject, because if you over-inject with Vox, it's almost impossible to undo that situation at the time, and I've had to remove some from patients a year or two down the line. So if you're going to do vocal fold injections under local anaesthetic, what do you need? Well, you need a number of different things. Firstly, a chip-tip endoscopic stack system, in other words, a distal chip system. You cannot do this using a fibre optic endoscope and a camera. I just think that the optics are simply not good enough. You need some local anaesthetic to numb the skin and the airway. You need the injection material you're going to use, obviously, and you need a competent assistant, because your assistant is going to be doing the endoscopy and you as the surgeon are going to be doing the injection. In my practice, my assistant is a speech and language therapist. So in terms of patient selection for local anaesthetic vocal fold injection, who is and is not appropriate for this procedure? Well, patients need to be able to tolerate nasendoscopy. And actually, in my experience, that's pretty much the only requirement. There are very few situations where a patient won't tolerate having an injection. Clearly, if you've got a patient who won't even allow you to examine them with a nasendoscope, then you're not going to be able to get on and do an injection. But the vast majority of patients are fine with it. I've said here that ideally the patient should not have a fixed flexion deformity, simply because if the patient's chin is on their chest, you're going to find it quite difficult to get the needle into the front of the neck. Having said that, this gentleman came and had an injection a few years ago under my care. He'd had extensive surgery and radiotherapy to his neck. And this is the full extent of his neck extension. And in fact, I was able to get a needle in through that small gap and into his cricothyroid membrane and do an injection for him. So that, I think actually, unless the chin is literally on the chest, I don't think a flexion of the neck is a major problem. I've said here that warfarin and aspirin are relative contraindications. I used to be fairly relaxed about warfarin and aspirin. I'm a lot less relaxed now, I have to say. I would, if at all possible, I would stop both. Aspirin 10 days beforehand, warfarin a few days beforehand. And if the patient is on warfarin for a metallic valve, then I would ask them to use bridging cover with self-injecting with a low molecular weight heparin to ensure that their valve doesn't clot off, and then they restart the injection some days later. No, they restart the injection that night, I should say. So in terms of the different techniques, the different approaches to injecting the vocal fold, I have only ever used a percutaneous technique. It is possible to use a via-channeled nasendoscope or even perorally, but I have in the past just used a trans-thyrohyoid or a trans-cricothyroid approach. So this is the thyrohyoid approach. You'll see some photographs and videos as we go along of this. Essentially, the patient's neck is extended and the needle is advanced into the thyroid, just above the thyroid notch, and the needle is then aimed downwards towards the paralysed vocal fold. And obviously you're watching everything on a screen for monitoring. And the thyrohyoid approach is my preferred approach for reasons I'll explain in just a second. The other approach is via the cricothyroid membrane, so from underneath, injecting between the cricoid and the thyroid. You see the needle appear in the subglottis and then aim the needle upwards. And again, you'll see some videos of that. It is possible to inject directly through the thyroid cartilage itself. Now, the theoretical advantage of that is that you're not going into the airway, so there's less coughing and there's less need for anaesthetizing the airway prior to the procedure. The disadvantage, of course, is that you're going through the thyroid cartilage, and in a lot of our patients, they're a bit older and the thyroid cartilage might be calcified. So that can make it quite difficult, and I've never gone through the thyroid cartilage to do this. It is possible to inject via a channeled nasendoscope as well. I have never done that. because actually the length, if you think about a TNO or TNE scope, the nasendoscope is actually really very long. The TNE scope is actually very long. So there's a huge amount of dead space between the syringe and the end of your channeled nasendoscope, and you would just lose a lot of the material. So I think you would probably end up using a couple of mils of syringe of injection material in the course of doing it. Perorally, I'll show you a photograph of the peroral approach in just a second. So in terms of preparing the patients for the procedure, there are various different ways of applying local anaesthetic to the airway. When I started out doing these, I started with having the patient nebulise on 4 mils of 4% lidocaine, or they gargle it, or you drop it in through a nasendoscope. Actually, I have found more recently that there's no particular need to anaesthetise the airway in that way. I tend to find that just injecting works very well, and I'll show you that in just a second. But if you are having the patient on a nebulizer, then you can leave them for 20 minutes while they're doing that. While the patient's having their topical anaesthetic, you can be asking them to fill in a VHI-10. I and my speech therapy colleague will do a GRBAS assessment, and immediately before that you can do a voice recording. So the technique of the local anaesthetic, if you're going through the thyrohyoid membrane, the approach for the local anaesthetic is exactly the same as the approach for the material for the injection as well. So with the neck extended, the needle goes in just immediately above the thyroid notch. I would tend to inject a little bleb of local anaesthetic into the skin, advance the needle a little into the pre-epiglottic space, inject a little more, and then see the needle appear in the airway. And I then would inject probably a couple of mils of 2% lignocaine directly into the airway itself. Now, at the point you go into the airway, and when you inject the local anaesthetic into the airway, the patient coughs and splutters quite a lot. That's fine. That's actually quite good, because you're washing the local anaesthetic up and down the airway, and it makes it pretty numb. So you then leave that for a minute or so while they get acclimatized to it. The upper airway is pretty anaesthetized. Incidentally, before doing this, obviously the nasendoscope is in the nose, and you're seeing the needle in the airway. So my speech therapy colleague is on one side of the couch, I'm on the other side of the couch. And the speech therapist has gone into the nose with the endoscope and is showing you the airway. So with the neck extend, this for the actual injection, the assistant is on the left side of the patient. I'm on the right side of the patient. I normally have the patient lying flat on the couch to do this, with the neck extended over the back of the pillow. And the speech therapist is right up close to the vocal folds, and I'm going to advance the needle through the thyroid notch, through the pre-epiglottic space and into the airway. Now, the approach for the thyrohyoid injection is really almost vertically downwards towards the feet, and you'd be surprised if you simply aim the needle in that direction, you will end up not getting into the vocal fold. So it's important that the needle is pointing almost vertically downwards, and I'll show you a trick for how to achieve that in just a minute. So I hope this video plays okay. This is a patient who's had their airway anaesthetized. The needle is appearing in the airway, and I'm going to aim laterally. So I'm aiming lateral to the vocal ligament into the thyroarytenoid muscle. It is paralysed right vocal fold, and here comes the injection material filling up the right vocal fold now. And at this stage, the patient might experience a bit of pain in the ear or pain in the throat. You can see that filling up nicely, and that's probably as much as one needs to do. Now, whereabouts on the length of that vocal fold would I inject? Well, I would typically inject wherever the concavity is most. So if the vocal fold is concave like that, I would usually inject into the point of maximum concavity and then fill that out, and then slightly overfill it, as you see in this photograph. So that's the cricothyroid, that's the, I beg your pardon, that's the thyrohyoid approach. So this now is the cricothyroid approach. Again, with a nasendoscope in the nose from one side of the couch, I'm on the other side of the couch. I'm going to inject some local anaesthetic into the skin over the cricothyroid membrane through the cricothyroid membrane itself and into the airway, and inject a couple of mils of lidocaine directly into the airway to numb it. The patient coughs as before. So I tend to enter the skin in the midline with my injection needle. This photograph I think is not quite right because it shows the needle off to the side, but I tend to start with the needle directly in the midline, advance it horizontally backwards, and with the screen you can see the needle appear in the subglottis. And here's the video of that. So we've got the nasendoscopy, and that's the needle appearing in the subglottis. Now, I'm just going to pause the video there because this immediately shows you one of the problems, which is that you don't actually see the needle in the as it goes into the vocal fold. You saw previously when I was going from above, coming through the thyrohyoid membrane, you can see the needle appear in the airway, and you can then direct it into the upper surface of the vocal fold. The trouble with injecting through the cricothyroid membrane is that because it's coming from below, you lose your sight of the needle as it goes into the undersurface of the vocal fold. As you'll see here, it's fine. You can feel a little give, a little kick as it goes into the vocal fold, but you don't see the needle point directly entering the vocal fold. And that's the filler material going in. So that's the trans-cricothyroid approach. Now, of those two approaches between thyrohyoid and cricothyroid, my preferred way of doing things is through the thyrohyoid membrane from above, because you can see the needle and you see exactly the point it goes into the vocal fold, and you have a lot of control. So for the majority of patients I'm doing, I would tend to use that approach. However, in women, it's sometimes difficult to feel the thyroid notch. And in those circumstances, if I can only feel the cricoid, then I will go above the cricoid and through the cricothyroid membrane and approach the vocal fold from underneath. Transorally, I have never done a transoral approach, I have to say. I think it's quite a fiddle. You would have to have the patient with a nasendoscope in, and with a long, rigid needle. The patient would have to pull their own tongue out, or maybe have the clinician pull their tongue out as well. The alternative in this approach, actually, is that you use a rigid 70-degree endoscope, and with the clinician using the rigid 70-degree endoscope and the injection needle, the patient then pulls out their own tongue, and you then only need one clinician to do the procedure. But that strikes me as being extremely cumbersome, and it's certainly just not something that I've ever got the hang of, and I've been perfectly happy with the transcutaneous approach via the cricothyroid or the thyrohyoid. So immediately after the procedure, what I'm going to do here is just to lose those annotations, because we've got some writing on the disabled participants annotation. There you go. So immediately after the procedure, or while the endoscope is still in, I tend to get the patient to cough a little, and that spreads the material evenly along the length of the vocal fold. And after 20 minutes or so, with the patient sitting out in the waiting room, they can then leave, and I don't have a particular problem with them going straight home. The only thing to bear in mind is that the local anaesthetic tends to last for quite a while. It lasts maybe an hour or so. So the patient must be told not to eat or drink until the local anaesthetic has fully worn off, or they might aspirate. After they've gone home, in terms of follow-up, for patients who are having palliative care, I would tend not to follow them up at all. And for other patients, I would see them 6 weeks down the line and then decide whether anything further needs doing. So for further treatment, if the injection wears off, whether it's...
Can I just stop you? Could you disable annotation from, when you see the more thing? There's if you push on more.
I have disabled annotation, but I can't get rid of that annotation that's on there. I can't hear you now.
The only way to do it is to stop share and start share again.
Stop share and start share again. Okay. Stop share. start share again. And I will, so I've now, okay, so you're not able to annotate, fine. Does that look okay now? Again, I can't hear you, but I assume that's okay.
That's good. Yeah, that's fine. Thank you. Perfect. Thank you.
Okay, thanks. So if the injection goes well and if it wears off, the injection can be repeated. And I'll show you a fairly straightforward algorithm that I tend to use when I'm thinking about managing patients in the longer term. If the injection does need to be repeated, that's absolutely fine. I would tend to say that if a patient's had a couple of injections, whether it be with calcium hydroxylapatite or with hyaluronic acid, then I would say that at that stage, they probably need to be thinking about something a little more definitive in terms of thyroplasty or of arytenoid repositioning. Let's just, there we go. Fine. So what are some of the potential difficulties of doing these injections? Well, if you've got a patient with a very big neck, then it can sometimes be difficult actually to get the needle into the correct position in the airway. I have to say that hasn't been an issue too much over the years that I've been doing these, but that can sometimes happen. If you over-inject a patient, it will result in the patient having a pressed and strained sounding voice quality. Now, I have to say, using calcium hydroxylapatite and hyaluronic acid, I have never managed to over-inject patients. I think it's really quite difficult to do. There are other materials like the Vox where it is possible to over-inject, but I've never over-injected using these other materials. On the other hand, I have managed to under-inject patients, and I think I was guilty of this when I started doing these. So I think you certainly have to over-inject a little bit at the outset when you do these injections, partly to allow for the fact that the carrier material is going to dissipate over a period of time. So, but under-injection is a potential problem. And then it is possible sometimes accidentally to to inject too superficially into the vocal fold, because clearly, as I said a moment ago, the layer that you want to get the injection into is the thyroarytenoid muscle. You do not want the patient to be injected into the superficial layer. Now, there's some chat going on here that I am going to just ignore, actually, I think, because I'll just carry on talking. So look, here's one of the situations where it's difficult to see the vocal fold. You'll be very familiar with this scenario. The false chords are very bunched up, and it's difficult to see the true vocal fold. So I've got my injection needle in there, but it's just impossible to see the upper surface of the vocal fold itself to inject. One of the techniques that I've developed is using a second needle in the neck as a retractor. So you're going to see in a second, this is another scenario that's very familiar, a left vocal fold paralysis with the corniculate cuneiform cartilage hanging over the laryngeal introitus, so you simply can't see the vocal fold. Now, what I do sometimes in this scenario is to put a second needle in alongside the injection needle and use the second needle as a retractor to pull the false chord or to pull the corniculate cuneiform out of the way. So this is that same patient where you can't see the true vocal fold. This is me with the retractor needle coming from above to push that out of the way, and so you can achieve adequate medialisation. Now, getting two needles right next to each other parallel in the neck is a bit of a fiddle, but entirely possible. So I've got a few top tips for you on how to achieve these injections under local anaesthetic in clinic. If you're going through the cricothyroid approach, you do need to bend the needle, but you just do one bend at the hilt of the needle. If you're going to go through the thyrohyoid approach, you need to do a double bend with the needle effectively creating a curved shape so that you can go in through the skin and then you follow the curve of the needle downwards and into the vocal folds from above. So I think a curve on the needle, if you don't do that curve on the needle and you're going through the thyrohyoid membrane, you won't get directly into the vocal fold and you will skirt over the top of it. So that curve is extremely important. With both approaches, it's important when you're in the first few seconds as you're going in that you stay in the midline all the way in, and then once you are into the needle. And the way to do that, rather than moving your elbow to get the needle moving, all you have to do is just to rotate the barrel of the syringe. And then by rotating the barrel of the syringe, you're either moving the needle to the left or to the right, but moving your elbow doesn't actually achieve very much. It's all about rotating the barrel of the syringe, and then once you're going in the correct direction, then you can advance the needle into the correct place. This is an area that the oncologists, and particularly the lung oncologists, are increasingly aware of and are alert to these days. And we're getting referrals from lung oncologists for patients who are having palliative care. And it's important, I think, if you're going to be doing these injections under local anaesthetic, to make your oncology colleagues aware that the service is there. And to encourage referrals in. They are enormously satisfying, and some of the most grateful patients I have had in my practice have been patients who are palliatively ill and who want to be able to speak to their relatives for the last few weeks or months of their lives. The injections do last out well. This is a relatively old paper now, but the injections last out well with the calcium hydroxylapatite, but it's not a permanent solution in all cases. And typical duration is around 18 months or so. So I think that an early injection is useful in many patients who need rapid rehabilitation of swallow, need to get back to work quickly, or having palliative care. But I would argue also that any patient who has a vocal fold, or the evidence is tending to show that the earlier you do a vocal fold injection, the less likely the patient is to subsequently need a thyroplasty. Whereas if you leave a patient for quite a long time before you're going to do something, then injection is less likely to work, and they are more likely after that to need a thyroplasty in the longer term. This is a paper back from 2013 looking at the timing of injection with a variety of different injectable materials. And the take-home message from this is that the earlier you inject a patient, the less likely they are further down the line to need a definitive laryngeal framework procedure like a thyroplasty. This is a much smaller set of numbers, but just demonstrating a similar thing, that the earlier you inject a patient, the less likely they are to run into problems in the longer term, and the more likely the vocal fold injection will last out permanently. And the way I explain it to patients is I say, look, we have an injection that takes a few minutes to do in clinic. If it works well, and if it works permanently, that's great, and you may not need anything further to be done. If it works well but wears off, then we have the option of another injection or a thyroplasty. But let's not jump the gun. Let's not go straight to a thyroplasty unless we absolutely have to. Because one injection will very likely be all that's required. The American Association of Endocrine Surgeons are on board with filler materials, filling agents for vocal fold paralysis. And there is a paper from a couple of years ago that demonstrated that an early injection, laryngoplasty, in other words, an early medialisation injection, may lower the risk of thyroplasty subsequently. And the third of those three papers just demonstrates that if you do an injection augmentation, if you do an IA, a medialisation injection in clinic, it does not affect whether you can do a thyroplasty further down the line. So can you inject in clinic a patient who has a large glottal gap on phonation? Well, yes, you can, and you might think to yourself that that sort of an injection wouldn't be as successful as a small injection, a small gap, I should say, and you'd be absolutely right. It's much more difficult to get a good long-term outcome with somebody who has a large glottal gap. But this is what this paper demonstrates. It also confirms that the early injection reduces the likelihood of needing a thyroplasty. This is a gentleman who has a large glottal gap on phonation. Medialisation. You can see that he's got an enormous gap on phonation. He's completely aphonic. He has no voice. And I didn't really hold out very much hope that we were going to get things much better for him. But in the end, we got the needle in, and as you'll see, he got a reasonable result from this filler material. Part of the problem here is that actually there's not very much vocal fold to aim at. So that's him having had his injection, and he's got quite a good result there. He's got better closure, and I'm going to over-inject just a little. When do I perform laryngeal framework surgery? Well, I certainly wouldn't do it before 9 to 12 months, and it is almost always after a patient has had a medialisation injection under local anaesthetic. Unless a patient has had a few failed injections before elsewhere, then my first aim would be for them to have an injection under local anaesthetic in clinic, and then to think about laryngeal framework surgery, a thyroplasty after that. When I'm doing thyroplasty, which implants do I use? Well, I previously used Silastic, which I used to carve myself and insert through a window in the thyroid cartilage. I found that absolutely fine, and that's what I was trained doing. But more recently, I've switched to using Gore-Tex. I use Gore-Tex ribbon, which is a centimetre wide and 10 centimetres long. It's extremely easy to do. Having incision in the neck and dissected onto the thyroid cartilage, you tuck in the Gore-Tex ribbon, I should say. And the advantage in my hands of using the Gore-Tex ribbon is that you can, if you need a little bit more at the back, if you need a little bit more at the front, if you need to move it around a bit, it's very, very easy to manipulate. You can just tuck it in posteriorly, tuck it in anteriorly, remove some if necessary. It's much easier to manipulate. And as I say, in my hands, it makes for a much quicker operation, and you can locate it very precisely. So this is my relatively straightforward, let me just move this so you can actually see what I'm talking about here. This is my relatively straightforward way of thinking about vocal fold paralysis, and just a very simple algorithm for how I'm managing patients. They're all offered an early medialisation injection. If I'm thinking they're going to recover over a period of time, if, for example, the thyroid surgeon was absolutely adamant that the nerve was intact at the end of the operation, and if you're clear that the laryngeal nerve is going to recover function, then I would inject to see what happens. Then going down, I would monitor them in clinic, and then if they deteriorate further, I would either offer them a repeat injection or more likely a thyroplasty. If you think that the paralysis is going to be a permanent paralysis, then I would offer them an early medialisation injection with calcium hydroxylapatite. If they achieve a permanent improvement, that's great. They're discharged from clinic. If the medialisation injection wears off, they can either have another one, or, as I say, if you think that this is going to be a more permanent issue, then I'd be talking to them at that stage about having a thyroplasty. In the future, I think we will be talking about re-innovation. There's a variety of different re-innovation techniques. I have to say I'm not doing them at the moment, but the biggest centre in the UK is Poole in Dorset, where Kate Heathcote and Reza Nouri are leading on it for the British teams. The re-innovation, a non-selective re-innovation can use ansa cervicalis to the distal stump of the recurrent laryngeal nerve. Now, of course, that will achieve a certain degree of tone and bulk of the vocal fold if it works, but it won't achieve normal movement. But that is an option at the time of thyroidectomy if nerve resection is required. Another option then is to do a selective re-innovation using a nerve interposition graft onto the stump of the recurrent laryngeal nerve. In bilateral vocal fold paralysis, well, that's a whole other topic in itself. I think historically, patients would have had a partial arytenoidectomy, and certainly in my hands, I'm in this situation usually doing a partial laser arytenoidectomy and hoping to avoid tracheostomy. Jean-Paul Marie in Rouen is leading on bilateral vocal fold re-innovation using the roots of phrenic nerve channeled into the posterior cricoarytenoid muscle, an extremely impressive operation, quite a long operation, and the results of that are still being gathered, but some early promise in that. So I'm going to wind up in just a second and take some questions if that's possible. I think it's fair to say that paradigms are shifting in how we manage patients with vocal fold paralysis, whereas previously we would have suggested that a patient waits for 9, 12, 18 months before having a surgical procedure or any sort of intervention for vocal fold paralysis. The current thinking is that patients should have an early injection under local anaesthetic in clinic, and in most places there will be a local centre that is able to do this. And if you're not doing them yourselves, then it would be worth thinking about where your local centre is, because it does make a huge difference to patients. Early injection, I think, is really important, not only for patients' lifestyle and ability to get back to work, but also because it means that in the longer term, patients are less likely to need a definitive thyroplasty or arytenoid procedure. And electromyography may be appropriate for patients who are keen to avoid an early intervention. I have to say, I very, very rarely do EMG because I'm going to be offering all of the patients an early injection anyway. Thank you very much indeed for your time. And Asana, I don't know if it's possible to take questions.
Yes, thank you very much.
Thank you. Can I just interject here? Dr. Ridwan Kalash is on the line. I unmuted his microphone, and he's our local expert here in Dubai on laryngology. Dr. Kalash, you wanna ask Declan the question?
Thank you, Dr. Muaz. Actually, I have a couple of questions, so it may not end actually, but I will summarize just several questions. There are wide variety of hyaluronic acid available in market. So there was only Restylane. Now there are Restylane Lips, Restylane Volume, Restylane Extra, and Juvederm and Juvederm Volia. So which one will you choose? And you have experience if there is anyone over another one, or for long lasting, for stability?
Yeah, I mean, I've tended to just use the standard Restylane that's come through to me, and we have generally in the past got it from our cosmetic clinics. I don't use Restylane with local anaesthetic in it because I'm going to be injecting local anaesthetic anyway. I'm trying to think of the exact preparation. I can check exactly which type it is, but I'm not using anything other than the very basic one.
And regarding the calcium hydroxyapatite, do you have any stiffness in vocal cords post after injection? I'm not familiar with, but I have one patient referred with the absence of mucosal wave after getting injection.
Yeah, so that is a potential problem. In one patient I injected, I didn't show you the video, but it's a patient who had previously had a thyroplasty. And he wanted a sort of top-up injection just to get slightly better closure. And trying to get into the vocal fold, every time I tried to inject, I was hitting up against the silastic implant. And in that case, I ended up injecting into the superficial lamina propria. Clearly that wasn't my intention, but the calcium hydroxyl apatite then spread along the length of the superficial layer, the superficial lamina propria. And yes, that caused a problem with his mucosal wave for sure. Now, as it happens, the mucosal wave on the opposite side was fine, and the result as far as this man's voice was concerned was okay, but that would not be my preferred way of doing it. So I think when you're doing it, you clearly have to be aiming as laterally as you can into the thyroarytenoid muscle.
Okay, thank you.
Declan, can you look at the chat line and answer the questions, because there are lots of them?
Okay, let's have a look at the chat line. Oh, right, here we go. So let me just read through some of these. Does the injection help in preventing aspiration too? Yes, it does. It improves the cough, it improves glottic closure, and it certainly improves aspiration. I've injected a few patients who have had significant problems with aspiration beforehand, and who have that's been resolved afterwards. So yes, that certainly does. Do you bend the needle thyroid approach? Yep, I do, and I've told you about that. What if the injection material drops in the airway? Good question. Well, actually, the patient can then just cough it up. It's not a big deal. You're never going to inject more than 0.1 of a mil. And if you see some of it extrude into the airway, just have the patient cough and swallow, and then they get rid of it. How long do you wait injecting after thyroidectomy for vocal cord palsy? I don't wait at all. If a patient has a vocal cord palsy in the days after a thyroidectomy, I would do an injection. And if the nerve has been sacrificed, they will have calcium hydroxide apatite. If the nerve has been accidentally bruised, then I will usually inject early with Restylane and then monitor them and see if the nerve recovers function. Because these days, patients want to get back to work a few weeks after thyroidectomy, and it's not reasonable to leave somebody aphonic for a long period of time before deciding whether you're going to do an injection. Let me just move this window so I can see. Oh, didn't mean that. Right, so where are we? Which size needle do you use? The needle that comes with the Radiesse Voice is a 25 gauge needle, which I think is just about right. Some people find that in patients who've got a thicker neck, the 25 gauge needle, which is quite delicate, can bend as you're going through into the neck, but I haven't really found that to be too much of a problem. If it is a problem, and if it's taking you several attempts in and out to get it right, then you can just use a fresh needle, but that's very rarely a problem. Bilateral abductor palsy, vocal cords fixed in paramedian position. We talked about that. My preference at the moment is, well, clearly my preference at the moment is to do nothing if I possibly can. Quite often patients are in this very difficult balance where they have enough of a glottic gap to just about get by breathing wise, and the vocal folds are close enough that the voice is just about okay. And if they're not perfect in either way, but manageable in both ways, then I would tend to leave things as they are. If the airway becomes compromised, then my preferred way of doing things initially is with a laser arytenoidectomy. I don't have any experience of doing suture lateralizations, but I know that a lot of people do. And clearly, in theory, at least, that's a reversible way of doing things, whereas a laser procedure is not. Is it important to ascertain the mobility of the cricothyroid joint? In other words, differentiating CAJ immobility from true vocal fold palsy? Yeah, I think that's a really good point. And I think that, cricothyroid joint immobility is pretty unusual. And I think we assume that most of the immobile vocal folds we see are due to a neurological issue, but every once in a while they will be due to cricothyroid joint fixation. But in answer to the question, I don't routinely palpate the cricothyroid joint because clearly that requires a general anaesthetic, and one assumes that the vast majority of immobile vocal folds are due to a neurological issue rather than to cricothyroid joint fixation. How long do you wait in unilateral cord palsy before going in for medialisation injection? We've talked about that. Wide variety of hyaluronic gel. Okay, we've talked about that. Fat injection. Yeah, I mean, I haven't used fat for a number of years. I've certainly never used it under local anaesthetic. I don't think anybody's using it under local anaesthetic. And I would, some people think that fat is great and lasts forever. And my experience of fat is that it does tend to wear off depending on how it's prepared, and for me, I just think that having something that's available off the shelf is a much easier way of doing it. Preferred gauge of needle we've talked about. Do I not allow for an intensive course of voice therapy before injection? Well, patients will always have voice therapy alongside whatever I'm doing in terms of injection. But I think if the question is whether you give them 6 or 9 or 12 months of voice therapy and then decide whether to do an injection, no, I don't do that, because I think that you then might be committing them to 6 or 9 or 12 months of having a very difficult voice and finding it difficult to work before then intervening. I think actually the speech therapy works much better if you can get in early with the injection and then build on that and allow them to build in good vocal habits in the longer term. Gauge of needle we talked about. Bilateral vocal cord palsy. How do you choose your side of cordectomy? How do I choose the side of cordectomy? I think I would do the cordectomy on the side. If there is a flicker of movement on one side, then I would do it on the opposite one. I would tend to do the one that looks entirely paralysed. Can you briefly explain, while performing posterior cordotomy, do you remove part of the vocal cord or vocal process? So no. So when I do a partial arytenoidectomy, when I do a laser procedure for bilateral vocal cord paralysis, I tend to leave the vocal process there, and I remove from behind that. I do a medial arytenoidectomy, leaving the vocal process intact. I don't do a cordotomy because I think that's relatively destructive. If the patient is still having problems with their airway down the line, then I will do a medial arytenoidectomy on the other side. And then beyond that, I think I'd start doing some more radical things. But a medial arytenoidectomy, a relatively conservative procedure, is what I do initially.
So thank you, guys, and thank you for joining us. Tomorrow we're going to have a live session. Dr. Roberto Meroldi, an excellent head and neck radiologist, is going to talk about dealing with non-nodal masses of the neck. And I really think you're going to enjoy tomorrow's session. Again, it's a live session, so you could ask Dr. Meroldi all the questions that you need. We had him before talking about salivary gland tumors, the radiology of salivary gland tumors. And I found that it was a terrific talk. And this is also a very practical talk. It's going to talk about how you take the patient through radiologic investigation when it's not a lymph node and when you have a neck mass. Thank you all. Have a nice evening, and I'll see you tomorrow.